What's up, dear medics? You're welcome once again to Health and Wellness. Here in Healthy Every Day, we study about medicine, about how to stay healthy every day. So, without wasting so much of your time, let's dive straight to business. Today, we are going to be talking about chronic heart failure. I am Dr. Anye Marion, and this presentation is supervised by Professor Ashutanta Gloria. This is an image of the heart. Heart failure is a bad, in fact, it's a beast. Are you seeing? So at the end of this lesson, we should be able to define what heart failure is. We should briefly describe the mechanisms of heart failure, list the causes of heart failure, list and briefly describe the mechanisms and symptoms of heart failure, list the diagnostic tests of heart failure and expected findings, list factors associated with progression of heart failure, list factors associated with poor prognosis of heart failure, list the complications of heart failure, list goals, strategies, methods, and management of heart failure. List the physiologic mechanism, clinical benefit and side effects of medications used in the management of heart failure. So as prerequisite, you have to revise anatomy of the cardiovascular system, the physiology of the cardiovascular system, and the semiology of the cardiovascular system. Definition of heart failure. This is our course outline. From there, we are going to talk about the epidemiology of heart failure, the pathophysiology of heart failure, list some etiologies of heart failure, the diagnostic approach to heart failure, and evolution and prognosis of heart failure. And then we are going to conclude with the treatment of heart failure. Heart failure is a complex clinical syndrome secondary to structural or functional abnormalities in the heart, which lead to the heart being unable to pump sufficient blood to supply the rest of the body with nutrients. So this can be either systolic or diastolic heart failure. Systolic heart failure is in case where the heart is unable to pump blood, hence there's a drop in the cardiac output, leading to poor supply of nutrients to the rest of the body. While diastolic heart failure is when the heart is unable to dilate in order to receive more blood from the body so that it can pump it. So heart failure can be acute or chronic, and it can also be left heart failure, right heart failure, or both. In case we call it congestive heart failure. It affects 1% of the population worldwide, and it has a high morbidity and mortality. 1 year mortality is about 35 to 55%, and also have a high socio-economic impact. This is the heart. Systolic heart failure, like as you can see, in systolic heart failure, the heart muscles, look at the heart muscle of the left ventricle, is too thin. It's too thin, it's unable to pump blood. Yes, the diastole is fine because it can, that large ventricular cavity can contain much blood, but the heart muscle does not have enough power to pump the blood to the rest of the body. And then now this a normal heart, you see, the muscle and the cavity ratio is just sufficient to maintain normal body function. And then if you look at in case of diastolic heart failure, the cavity is too small, so hence the heart cannot contain enough blood since there's no enough preload. We call it preload, the amount of blood they stretch in the heart muscle before systole is called preload. So the amount of blood that enters the left ventricle just before systole is too small in case of diastolic heart failure, and hence not sufficient blood is being pumped to the rest of the body. And as non-sufficient blood is being pumped to the rest of the body, there's no enough oxygen and other nutrient delivery to the peripheral tissue, and hence heart failure. The physiology and pathophysiology of heart failure. Cardiac output equals to heart rate times stroke volume. Blood pressure equals to cardiac output times heart rate times peripheral equals to stroke volume times heart rate times peripheral vascular resistance. So the blood pressure can be also be defined as the cardiac output times the peripheral vascular resistance. If you don't, you can check the last video on hypertension to better understand this concept. Preload. We're talking about preload. Preload is the stretch in the left ventricular wall is a stretch just before systole and is related to the amount of blood that enters the left ventricle. The more the blood that enters the left ventricle, the more pressure builds up within the left ventricle. The more pressure builds up within the left ventricle, hence there's a stretch on the myocardium of the left ventricle. That's what they call preload, that tension. So the higher the preload, the higher the contractility and the higher the cardiac output, and hence the higher the blood pressure. Contractility is the force with which the myocardium, that's independent myocardium, contracts. Is the force with which, in fact, in simple terms, is the force with which the left ventricle contracts to eject blood out into the aorta. Is the force with which the heart contracts. And it depends on the sympathetic nervous system because this force is controlled by the sympathetic nervous system. The afterload is the resistance to ejection of blood from the ventricle. Like this is the pressure that is found in the aorta and the pulmonary arteries that the left ventricle and the right ventricle must overcome in order to pump blood into those vessels. So, in case of hypertension, like let's just say in case of systemic hypertension, the afterload is going to be very high because the pressure in the aorta is really high. So the left ventricle has to pump blood so hard in order to force the blood through the aorta. So in case of systemic hypertension, the afterload is high. In case of pulmonary hypertension, the afterload in the right side is also high. And this also depends on the vascular resistance. So if there's an increase in the vascular resistance, there's going to be an increase in the blood pressure. If there's an increase in the blood pressure, there's increase in the afterload. Okay, let's talk about the pathophysiology and mechanism of heart failure. An increased preload. That's the first one. Increased preload. No, sorry, it's supposed to be a decrease in preload. A decrease in preload. In this case, it leads to diastolic dysfunction because the ventricles become stiff. Since the ventricles are stiff, they cannot dilate enough to contain the sufficient amount of blood to be pumped to the entire body. In this case, we can have examples like hypertrophic cardiomyopathy, ischemic heart disease, and infiltrations such as restrictive cardiomyopathy, in which the ventricles cannot dilate enough to contain the sufficient amount of blood to be pumped to the entire body. The ventricles become stiff. So there's going to be blood build up in the ventricles, which will eventually backflow. In case of right heart failure, it's going to backflow into the liver and the rest of the body, into the superior vena cava, the jugular veins, leading to jugular venous distension, into the liver, leading to hepatomegaly and hepatalgia and ascites, and then back to the limbs, leading to pedal edema. In case of left heart failure, the backflow is going to be towards the lungs, leading to what they call lung congestion and pulmonary edema. So the second is a decrease in contractility. This is when the heart muscles do not contract with sufficient force to send blood to the entire body. Let's take, for example, in the case of the right ventricle does not contract with enough force to send blood to the lungs, and in case for the left ventricle does not contract with enough force to send blood to the entire body. Yeah, think for a second. Examples could be stuff like dilated cardiomyopathy. In case of dilated cardiomyopathy, the heart muscles are too thin in a way that it cannot produce enough force to pump blood to the entire body. In case of ischemia, the necrosed section of the heart, an infarction, the infarcted muscles don't contract, and hence there's no enough force developing to pump blood to the entire body. Okay, now we'll move to increased afterload. Increased afterload on the right is what we call hypertension, and on the left is what we call pulmonary hypertension. I mean, on the left is what we call systemic hypertension, and on the right is what we call pulmonary hypertension. If the blood pressure in the great vessels are too high, the right and the left ventricles has to pump blood with sufficient force in order to overcome the pressures in the great vessel. In case of the right, in order to pump blood into the lungs, the right ventricle has to overcome the force, the pressure in the pulmonary artery. And in case of the left, in order to pump blood to the whole body, the left ventricle has to overcome the pressure in the aorta. Think for a second, things that can cause increase in the afterload. We can have pulmonary and aortic stenosis, valvular disease, stenosis. We can have systemic hypertension and pulmonary hypertension. Systemic hypertension, what can cause systemic hypertension? We can have coarctation of the aorta, aortic coarctation, and in case of the right, we can have what they call pulmonary embolism, and we can also have what they call cor pulmonale, things like chronic bronchitis and a chronic lung disease leading to a right heart failure due to increase in the pulmonary arterial pressure. We can also have obstructive cardiomyopathy in case of hypertrophic obstructive cardiomyopathy. Yes, on the left. Now let's discuss about the compensatory mechanisms of heart failure. The tissue don't receive enough blood, hence they don't receive enough oxygen. The first compensation mechanism that happens is the heart begins to pump blood at a faster rate in trying to compensate, because an increase in the heart rate is going to lead to an increase in the blood pressure, and hence an increase in flow and delivery of oxygen to the body. So the heart is going to try to compensate by increasing the heart rate. But in a long run, an increase in heart rate will lead to a decrease in ventricular filling time. And if there's a decrease in ventricular filling time, there's going to be a decrease in the preload. And when there's a decrease in the preload, there's going to be a decrease in the stroke volume and a decrease in the cardiac output, further worsening the heart failure. So from the beginning, increased heart rate is a good compensative mechanism, but with time, there's going to be a decompensation. Peripheral in the periphery, there's sympathetic system activation, and there's renin angiotensin aldosterone system activation. This is in order to increase the blood volume and hence increasing the blood pressure. As you see this compensatory mechanism, when you increase the blood volume and hence increasing the blood pressure, when you increase systemic vascular resistance, the blood volume and the blood pressure, this is going to lead to an increase in afterload, leading to a decompensation of the heart failure. So from the start, these compensation mechanisms are good, but in the long run, there's going to be a decompensation. That's a worsening of the heart failure. This is a diagram showing the compensatory mechanism. Like you see, there is myocardial dysfunction either due to ischemic heart disease, hyperthyroidism, myocardial infarction, valvular disease, alcohol, and the rest, etc., which leads to a drop in cardiac output, a drop in systolic blood pressure, and a decreased perfusion to the kidneys. Decreased perfusion to the kidneys obviously leads to the release of renin and begin the renin angiotensin system, which converts angiotensinogen right down to angiotensin 2. Angiotensin 2 has a lot of functions. One, it releases aldosterone, leading to water retention in the kidneys, increasing the blood volume. It causes vasoconstriction, increasing the peripheral vascular resistance. All these mechanisms is just to make sure that there's an increase in the blood pressure. From the start, obviously, it's a good thing, right? Okay, but later, this increase in the blood pressure is going to increase the afterload, leading to a further decompensation of the heart failure. Mechanism of anemia in heart failure. Yes, this is what they call heart failure with high cardiac output, because due to anemia, it's not that the heart is not functioning well, it's anemia, and anemia leads to reduction in hemoglobin. If there's a reduction in hemoglobin, there's a reduction in oxygen delivery to the tissues. Hence, the heart will try to compensate for that as well. So let's move straight to the etiologies of heart failure, having understood the pathophysiology and the compensatory mechanisms. We said heart failure can be classified as either diastolic or systolic heart failure. And we also said it can be classified as left or right heart failure. Okay, let's just take a brief revision of left and right heart failure. In case of right heart failure, there is right ventricular failing. It could either be systolic failing or diastolic failing. This is going to lead to less blood being pumped out of the right ventricle and less supply of blood to the lungs. And it's also going to lead to backflow of blood from the right ventricle into the right atrium, into the superior and inferior vena cavas, to the jugular vein and the brachiocephalic veins, and then to the inferior vena cava down to the liver. This is going to lead to what they call hepatic congestion. So we're going to have hepatomegaly, we're going to have jugular venous distension, we're going to have what they call hepatojugular reflux, which occurs when you palpate at the level of the right hypochondriac region and there's an increase in the jugular venous pressure. Also, we're going to have what is called uh, lower limb edema due to backflow of blood to the limbs, and we're going to have ascites. Okay, in case of the left, there's backflow of blood where to the lungs, leading to what we call pulmonary edema. This one will manifest as dyspnea, where you have difficulties in breathing, and then autopnea, where you have difficulties in breathing when lying down on the back. Also, we can also have um, fine crackles on auscultation on the lung fields, and we can have a cough with a pinkish or photic sputum, a productive cough to be precise. Okay, the etiologies of heart failure, let's dive straight into it. Systolic dysfunction, we already listed some of these etiologies, so this is just a recap. Ischemic heart disease, the necrosed area of the myocardium is not going to contract, hence there's going to be a decrease in the contractility of the heart and leading to a decrease in stroke volume and hence heart failure. Valvular heart disease such as mitral regurgitation, such as aortic or mitral stenosis and regurgitation. In this case, the ventricle is fine, oh, yes, but the heart contracts, but there's an increase in the afterload. In case of aortic stenosis, there's an increase in the afterload in which the heart contracts, but not enough blood leaves the ventricles because the aortic valves are too stiff, they don't open as much, and hence the passage of blood is narrow. So we have hypertension, is the same mechanism with aortic stenosis. We have dilated cardiomyopathy. We discussed this. In case of dilated cardiomyopathy, the cardiomyocytes, the myocardium is so thin in a way that it cannot generate enough force to pump blood. In hypertrophic cardiomyopathy as well, this can also cause systolic dysfunction because hypertrophic cardiomyopathy can obstruct the outflow tract, the left ventricular outflow tract, that is the tract leading to the aorta. It can obstruct it, and hence not enough blood is being pumped into the aorta and to the rest of the body. Arrhythmias, things like atrial fibrillation, ventricular tachycardia, this leads to low ventricular filling pressure and it leads to a reduction in the ventricular filling time, and hence there's a low ventricular filling pressure. It leads to a reduction in the preload. A reduction in the preload is going to lead to a reduction in contractility and hence heart failure. Congenital heart disease, stuff like coarctation of the aorta, we discussed that. High output cardiac failure, in this case the heart is pumping blood like hyperthyroidism, anemia, beriberi, Paget's disease, arteriovenous fistula. In this case the heart is pumping well, but oxygen delivery to the tissues is not sufficient. Like in case of anemia, there's a low hemoglobin and there's no transportation of oxygen to the tissues. In case of hyperthyroidism, there's a lot of energy expenditure at the level of the tissues. There's a lot of oxygen consumption due to hyperthyroidism, and hence the heart pumps blood too frequently. There's an increase in the heart rate. The heart has to struggle to meet up with the body's demands. Okay, let's move to diastolic dysfunction. Ischemic heart disease can cause both systolic and diastolic dysfunction because in the case of diastolic dysfunction, ischemic heart disease, the necrosed or the infected cardiomyocytes cannot dilate, are not elastic enough to dilate and receive enough blood, hence leading to diastolic dysfunction. In case of hypertension from the beginning, it leads to what they call ventricular hypertrophy. But if it's pulmonary hypertension, it leads to right ventricular hypertrophy. If it's systemic hypertension, it leads to left ventricular hypertrophy. As there's hypertrophy of these ventricles, there's a reduction in the cavity of these ventricles, and hence there's a restriction of blood entering these ventricles. Restrictive cardiomyopathy is self-explanatory. Constrictive pericarditis, in this case, the pericardium is not stretching enough to contain the blood when it enters the left ventricle. When the left ventricle tries to stretch and contain the blood, the pericardium that surrounds the left ventricle does not stretches, and hence there's a restriction to blood entering into the left ventricle. Okay, we had discussed about the etiologies of systolic and diastolic heart failure. Now let's discuss the etiologies of right heart failure. This is going to apply to the left as well. We already discussed what left heart failure is. We discussed what right heart failure is. Now we're going to the etiologies. The most common etiology of right heart failure is what we call left heart failure. You can be surprised, but that's the fact. A left heart failure is going to lead to backflow of blood into the lungs. This backflow can continue right to the pulmonary capillaries and to the pulmonary artery, leading to what we call pulmonary arterial hypertension. Pulmonary arterial hypertension can lead to increase in the afterload on the right, and if there's an increase in the afterload on the right, it leads to systolic heart failure of the right. So that's right systolic ventricular failure. So also we have what we call cor pulmonale. It's the same mechanism, but this occurs due to a chronic lung disease, like in case of pulmonary embolism, chronic obstructive pulmonary disease, lung fibrosis, and pulmonary hypertension. Oh no, all of this leads to pulmonary hypertension, and pulmonary hypertension now leads to right heart failure. In case of cor pulmonale, there is decrease, there's a reduction in the VQ ratio. The VQ ratio is ventilation perfusion ratio. That means that there's decreased ventilation with a normal perfusion due to lung disease. And if there's a decrease in ventilation supplying a particular pulmonary capillary, and okay, let me explain it this way. There is a decrease in ventilation and there is a normal perfusion leading to a decrease in the VQ ratio. This is due to a chronic lung disease. When there's a decreased ventilation in the lungs, what happens is that the pulmonary capillary supplying that particular alveoli constrict, constrict in order to get more oxygen from the healthy lungs. So that constriction leads to a backflow of blood. That backflow now leads to a buildup in pressure proximal to the constriction, hence leading to what we call pulmonary hypertension and right heart failure. That's what we call cor pulmonale. Acute cor pulmonale is just a faster, it's just an acute mechanism, but it's the same mechanism. Ischemic heart disease like right myocardial infarction can lead to a systolic right heart failure. Valvular disease like tricuspid regurgitation from endocarditis, pulmonary stenosis, pulmonary regurgitation, and the rest. Those can lead to right ventricular failure. On the left, will be aortic and mitral stenosis, aortic and mitral regurgitation. Congenital heart disease like transposition of great vessels and other congenital heart diseases. Others like tumor and arrhythmias, all of this can lead to right heart failure. So all of this also applies in case of left heart failure. I hope we're understanding. Now, let's go to the diagnosis of heart failure. We have already spoken about the diagnosis of heart failure based on when we're talking about right and left heart failure. Right heart failure leads to congestion in the peripheral tissue. Left heart failure leads to congestion in the lungs. So in the peripheral tissue, we have edema, ascites, hepatomegaly, jugular venous distension, hepatojugular reflex. That's right heart failure. Left heart failure, congestion in the lungs, we have pulmonary edema, cough, dyspnea, autopnea, cyanosis, like signs of hypoxia, cyanosis. You can screenshot this to read it again, but we are going to be repeating it throughout this video, so it should stick. Okay, clinical diagnosis and diagnosis test in case of left heart failure. Like we said, we're going to have shortness of breath, which is dyspnea. To be precise, exertional dyspnea, it happens on exertion and is graded using the New York Heart Association grade. Like grade 1 is on effort, grade 2 mild effort like trying to climb a stairs, grade 3 just doing your daily activities you have dyspnea, and grade 4 even at the rest you have dyspnea. That's how we grade it using the New York Heart Association scale. And then we have autopnea. That's when you feel when you have dyspnea when lying down. And then we have paroxysmal nocturnal dyspnea. This one happens in when the patient might just be sleeping at night, then the patient wakes up and goes to the window to go and catch the breath. So it's a nocturnal dyspnea. That means that it happens at night and when the patient does not know. We have exertional cough. This cough might aggravate by night while lying down, and is productive and has a faulty sputum. This sputum might be pink or red, asthenia or exertional fatigue. And then we have weight gain, digestive disorder, and psychomotor slowness. These ones are rare symptoms, so you rarely find them. For physical exam, we are going to follow the inspection, palpation, percussion, and auscultation. So we have a low blood pressure, a tachycardia, a displaced apical pulse. The apical pulse is the apex beat where we auscultate at the feet intercostal space mid clavicular line. Is to auscultate the mitral valve. So this might displace to the left in case of left ventricular hypertrophy, like can displace from the feet to the seat intercostal space anterior axillary line instead of the mid clavicular line in case of ventricular hypertrophy. And then we might have an S3 gallop in case of ventricular hypertrophy. We might have murmurs in case of valvulopathies and a loud S2 heart sound in case of pulmonary hypertension. Long auscultation, we might have fine and aqueous crackles in case of pulmonary edema due to left heart failure. As complementary tests, we need a 12 lead resting ECG. This could show us left ventricular hypertrophy, could show us myocardial infarction. It could show us in case of pericarditis as well. We need a chest X-ray to check for pulmonary edema and cardiomegaly. A cardiac ultrasound, this is primarily to check the ejection fraction. The ejection fraction is the difference between the diastolic filling and the stroke volume. That means that the end diastolic volume minus the stroke, the ejection fraction is the amount of blood that leaves the ventricle. That means that if you take the end diastolic volume with the ejection fraction is the stroke volume divided by the end diastolic volume times 100. So it's calculated in percentages. So it should generally be greater than 40%. So if it's greater than 40%, we can have heart failure with preserved ejection fraction. If it's less than 40%, we can have heart failure with decreased ejection fraction. So the cardiac ultrasound is to check for the ejection fraction and diagnose the heart failure based on that, and also to check for things like valvulopathy. Even myocardial infarction can be checked using the cardiac ultrasound. Other biochemistry tests like the atrial natriuretic peptide it happens when there's a stress on the right ventricle, on the right atrium. Yes. So there's excess secretion of atrial natriuretic peptide. So if it's increased, we can suspect heart failure. We can also check for lactate dehydrogenase in case of myocardial infarction. And we can check for cardiac enzymes like troponin I and creatinine kinase MB in case of myocardial infarction. So these are this is a picture to just show you the signs and symptoms of left heart failure. You can see restlessness, confusion, autonomia, tachycardia, exertional dyspnea, fatigue, cyanosis, paroxysmal nocturnal dyspnea, elevated capillary wedge pressure, pulmonary congestion, that's cough, crackles, wheezes, blood tinge, sputum, and tachypnea. Right heart failure, we had also discussed about this. You have asthenia, you have weight gain, digestive disorders such as hepatalgia. We talked about it, and hepatomegaly. This is due to congestion of the liver. We have hemoptysis as well. So there's jugular venous distension, and hazard sign is in case of right ventricular dilation and right ventricular hypertrophy. This tender hepatomegaly is what we call hepatalgia. There's hepatomegaly that is tender, pain on the liver. So we have ascites and pedal or sacral edema. On auscultation, we might have a gallop or a loud S2 in case of pulmonary hypertension, and you might have crepitations in case of COPD. COPD can lead to, chronic obstructive pulmonary disease can lead to pulmonary hypertension and hence heart failure. That's in case of cor pulmonale. So complementary test also 12 lead EKG, Chest X-ray is the same with left heart failure. So these are signs. This is a brief illustration in case of right heart failure. So this the EKG, the 12 lead EKG. In myocardial infarction, you can see we can have ST segment elevation. In atrial fibrillation, we can have irregular heart sounds. So this chest X-ray diagnostic finding, this pulmonary edema, what we call cardiogenic edema, yes, with cough. This is the normal finding in chest X-ray, the first image up. Then down here, this in case of left heart failure. You can see we have pulmonary edema. There's just diffuse opacities. It's what we call interstitial syndrome. Diffuse opacities on both lung fields. It can even lead to pleural effusion. This cardiac ultrasound. The normal findings in cardiac ultrasound, the heart has 4 chambers and the chambers are completely filled. The ejection fraction is normal. In case of valvulopathy, you can see them on cardiac ultrasound. Then biochemistry. Anemia can lead to high output cardiac failure. Well, we have to also do tests for diabetes. We have to do a lipid profile for in case of arteriosclerosis to test for arteriosclerosis that can lead to myocardial infarction. Yes, we have to do the kidney function because as differential diagnosis of heart failure, we can have kidney failure and liver insufficiency or liver cirrhosis because all this can lead to edema and ascites. So we have to do all of these complementary tests. A brain naturating peptide, that's actual naturating peptide of greater than 400 or a pro-brain naturating peptide of greater than 2000 is diagnostic of heart failure. So we're going to continue with the evolution, complication, and prognosis of heart failure. We have progressive factors of heart failure. These are the compensating factors of heart failure, which we can have is arrhythmias, hypertension, ischemia, endocarditis, renal failure, anemia, hyperthyroidism. In fact, there are many decompensating factors for heart failure, but the most common we have is infection, myocardial infarction. Those two are the most common. And complication of heart failure, this could lead to sudden death, ventricular tachycardia, pulmonary embolism, cardiogenic shock, and it can lead to infections. And these infections can further decompensate the heart failure, leading to a vicious cycle of positive feedback. Prognosis of heart failure. 1 year mortality is 35 to 55% in all patients in stage 3 and 4 New York Heart Association heart failure. Factors affecting prognosis, we have the age, ischemic heart disease, persistently low blood pressure, New York Heart Association stage 3 and 4, a low ejection fraction, hyponatremia, renal failures, hyperbilirubinemia. All these things can can cause poor prognosis. Now, let's move straight to the treatment of heart failure. We have the acute management and the long-term management. In this video, we are going to be looking more at the long-term management. We're going to look at the acute management of heart failure when we are managing for shock. So for our goals of management of a patient with heart failure is to relieve the symptoms and improve the quality of life, to reduce the number and duration of hospitalizations, to reduce mortality associated with heart failure, and to slow the progress of the disease. As strategy, one is to reduce congestion. And reduction of congestion is we do this by salt and water reduction and diuretics, loop diuretics to be precise, and anti-aldosterone, but the most common is loop diuretics. We have to increase the contractility with cardiotonics such as digoxin, adrenaline, dobutamine. And we have to reduce preload, that's vasodilators, using nitrates, ACE inhibitors, salt water restriction, diuretics. We are also to reduce the afterload using ACE inhibitors and angiotensin receptor blockers because these are medications that stop um, the renin-angiotensin system, leading to a decrease in blood volume and hence a decrease in the afterload. So we also block neurohormonal toxicity like with ACE inhibitors, beta blockers, and spironolactone. So the means we have known pharmacological means: rest, exercise, salt and water restriction, weight loss, stop toxins. Pharmacological means we have ACE inhibitors and angiotensin receptor blockers. These are to prevent remodeling of the heart. We said that in our hypertension video, and improve the mortality in case of heart failure. We also have spironolactone and digoxin. Digoxin is to increase the contractility of the heart and to reduce the rate, to reduce tachycardia. Surgical instrumentation such as resynchronization, defibrillation, and left ventricular assist device, bypass or valvuloplasty, and heart transplant. These are surgical means of managing heart failure and they are not so common, especially when we're talking about medicine. So these are medications: ACE inhibitors, beta blockers. ACE inhibitors decrease preload and afterload. So it's a very good medication. And like we said, it helps to improve the mortality in patients with heart failure. But they have side effects such as acute kidney injury, hyperkalemia, hypotension, cough, and angioedema. Examples include captopril, enalapril, lisinopril, ramipril, and they also have beta blocker. This one increases the contractility and hence the stroke volume. It decreases the afterload and it decreases the heart rate. We saw that increase in heart rate was a compensatory mechanism to heart failure, but in a long run, it instead leads to the compensation of the heart failure. So beta blocker helps to decrease the heart rate. We have bisoprolol, carvedilol, metoprolol, atenolol. All of these are cardioselective beta blockers, which means it targets the beta 1 receptors in the heart, only in the heart. It does not go to the beta 2 receptors. Angiotensin receptor blockers work exactly like ACE inhibitors, but it has less side effect, no cough, no angioedema. Anti-aldosterone um, works exactly like angiotensin receptor blockers as well. It works as a diuretic. It decreases absorption of water and sodium at the level of the distal convoluted tubules of the kidney, hence reducing blood volume, hence decreasing the afterload and the preload as well. Diuretics or natriuretics, these ones help to eliminate sodium and water, hence decreasing the blood volume and decreasing the afterload. Digitalis, these are cardiac glycosides which help to increase the contractility of the heart and increase the tone of the blood vessels as well. So we have something like digoxin. It's also used for rate control in case of arrhythmias. Others like vasodilators are used to decrease the preload and afterload. Vasoactive amines used in case of cardiogenic shock like dobutamine, adrenaline. These are used to increase the peripheral vascular resistance and help to increase the blood pressure. This is in case of shock because and in acute settings because if used in long term, it's going to decompensate the heart failure instead. Things like anticoagulants and antiplatelets are used in case of ischemic heart disease. Something like clopidogrel and aspirin are especially used in ischemic heart disease when the lipid profile reveals hyperdyslipidemia. Yes, we can use aspirin and clopidogrel. In case of anemia due to iron deficiency, we can give iron. So, management of systolic heart failure. New York Association Class 1 ACE inhibitor beta blocker spironolactone. This slide, make sure you screenshot this slide. Screenshot this slide so that I can go through it again. Stage 2, Class 2 ACE inhibitor beta blocker spironolactone and loop diuretics. New York Heart Association class 3, this is where we need rate control with beta blocker, and this is where we need um, something to increase the contractility, such as the digoxin. In stage 4, then we need um, we need adrenaline or dopamine. So these are the stages. This is just an illustration of the stages with the medications that are used in treating them. It's very important to go through this. Treatment of diastolic heart failure. Diastolic heart failure with ejection fraction greater than 50% is seen in patients. Is seen in 50% of patients. That means that in this case, there's a diastolic heart failure, which means there is, like we explained, there is decrease in the blood flow entering the ventricles because there's stiffness in the ventricles. In this case, most of the times the ejection fraction is going to be normal because systole is normal. Yeah, so the ejection fraction is going to be normal. There's no standardized treatment, but we can consider using ACE inhibitors, angiotensin receptor blockers, beta blockers, and aldosterone, even diuretics. That's if there is congestion. Calcium channel blockers such as verapamil and diltiazem, these are non-dihydropyrimidine calcium channel blockers. So these are the medications that we can consider, but there is no standard treatment for this for patients with this type of heart failure. Welcome to the end of our video, but before we close, let us summarize what we have learned so far in chronic heart failure. When there is a right heart failure and there's a left heart failure occurring at the same time, that's what we call congestive heart failure. Okay, heart failure is a clinical syndrome. Typical symptoms and signs of congestion and poor perfusion. On the right, congestion in the lungs. On the left, congestion in the rest of the body. There's poor perfusion to the body. This is confirmed by echocardiography with determining the ejection fraction, and the response to treatment is pretty good. The disease is frequent and has a high morbidity and mortality, and it's a progressive disease, hence there's going to be frequent follow-up. Our treatment, the goal is to improve the quality of life, and pharmacological, we have ACE inhibitors, beta blockers, spironolactone, and diuretics. Non-pharmacological, Fowler's position, rest, salt and water restriction, and BP control, and others. Diet. Let's take this one case scenario before we end this presentation. Mr. DR, a 73-year-old man who presented in your clinic for cough, especially at night, productive mucopurulent sputum. This was associated with a recent onset of shortness of breath with rapid worsening. His medical history was remarkable for type 2 diabetes, treated with twice daily metformin 500 milligrams, and systemic hypertension, treated with once daily with verapamil 240 milligrams. While he was undressing for the physical exam, you notice he became short of breath. His weight was 92, that is, he gained 4 kilograms of weight for a height of 1.74. His pulse was regular at 100 beats per minute. The blood pressure was 130 on 80 millimeters of mercury. His axillary temperature was 38.2 degrees. On heart auscultation, there was a third heart sound with no murmur. On lung auscultation, you heard bronchi, discrete wheezes, and inspiratory crackles at the lung bases. The liver was slightly enlarged and tender. There was mild bilateral pitting edema. The rest of the physical exam was unremarkable. You performed a urine dipstick that was remarkable for mild proteinuria. Request for some tests as shown below. Glycemia was 1.2 grams per liter. Hemoglobin, glycated hemoglobin was 7%. Creatinine was at 110 micromoles per liter. Kalemia 4.1 millimoles per liter. Natremia 138 millimoles per liter. Total cholesterol 2.4 grams per liter. HDL 0.4 grams per liter. LDL 1.6 grams per liter. Triglyceride 2 grams per liter. and we have this as the chest X-ray. ECG findings, standard recording, and these are our electrocardiogram findings. A left ventricular ejection fraction of 40%, a thin wall, scarred myocardium segment, normal valves, normal pericardium. Answer the questions and give the answer in the comment section below, and we should go and we're going to go through them. But it's a very interesting case, and if you cannot answer any of these questions, I'll advise you to rewatch the video. Thank you for your time. Thank you for your patience. Thank you for listening. Don't forget to subscribe to the channel, and don't forget to give us a thumbs up. Don't forget, this is going to help us a lot. It's going to support us so that we can continue with the work we are doing. Thank you for listening. Thank you for everything. Thank you, guys.